Welcome to APGAP 2020. 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 Welcome to APGAP 2020.
Good evening and a warm welcome to all those who are present today on the first of the 3 workshop sessions for APGAP 2020. As the saying goes, tell me and I forget, teach me and I may remember, but involve me and I learn. Workshops and hands-on training have always been a part of APGAP since its inception. In an effort to keep with tradition in these changing times, we bring you the best of the best. Dr. Deepika and I, Nisha, will guide you through today's workshop session on transthoracic echocardiography. And before we begin, we would like to brief you about the structure of the workshop for today. The workshop is split into 2 sessions with a break in between, during which time we shall conduct the podium presentation. A gentle reminder to all our viewers, registrations are closed as of now. Interested candidates can watch the lectures on the Manipal Anesthesia e-learning YouTube channel.
Kindly submit the feedback form, which shall be made available on the website from 8th November to 10th November 2020. E-certificates for the CME will be sent to your registered email after submission of the feedback form. As mentioned earlier, the Karnataka State Medical Council has granted 2 CME credit points for APGAP 2020, and those who have registered before 28th of October with their medical council registration number and have attended the sessions for at least 4 days or more shall be awarded these points on their certificate. Others will receive a certificate of participation from the organizing team.
Also, similar to previous sessions, any queries or comments may be posted in the YouTube comment section on your screens and will be addressed at the end of the session by our speaker.
As we begin, have you heard someone say, "Turn off the lights, I can't see"? Ironic as it may sound, that's the window into the hardest working organ of the body, the heart. The last decade has seen the emerging role of the anesthesiologist as a perioperative physician. TTE or transthoracic echo, not only in the intraoperative and the postoperative period, but even in the elective outpatient pre-admission anesthetic clinics, can help clinicians in actual decision-making at critical moments to enable the most appropriate management.
Our speaker today, Professor Justiaan Swanevelder, is a professor and head of Department of Anesthesia and Perioperative Medicine at UCT Groote Schuur and Red Cross War Memorial Children's Hospital. He specializes in adult and pediatric cardiothoracic anesthesia and critical care and is a strong believer in enhancing preoperative outcomes through the use of echocardiography and ultrasound. He is a prominent member of the European Association of Cardiothoracic Anesthesia, and he hopes to establish the value and safety of point-of-care medical ultrasound in critically ill patients in the developing world. Our session today is coming to you live from Cape Town, South Africa. As you can imagine, this is a technically challenging task, and we request you to kindly bear with us in the event of any unforeseen technical glitches. We are sure that this will turn out to be an eye-opening experience for all those who are present today. We are honored to have you, Dr. Swanevelder, amongst us today. Over to you, sir.
And video. Yeah, okay, so I cannot start my video. They can start my video. Okay. So, ladies and gentlemen, Professor Anita Shenoy, Professor Manjunath Prabhu, and other esteemed colleagues from Manipal University. It gives me such great pleasure to be here, and bear with me if I just say a few words before we get started on this very important topic of point-of-care ultrasound and the value of it. I just want to start to say thank you very much to not only Philips, who is a big supporter on our side here in our department, but also our AVICOM, Suleiman Razak and Craig, our audiovisual people, and also Paul Rousseau, who spent a lot of time setting up. It was, as the previous introducer mentioned, it's technically quite difficult to do something in such a remote location and on a distance. But it gives us great pleasure to be part of your refresher course and workshop. I met Professor Shenoy, Anita, in 1995 when I arrived in Leicester, and we were working together there as colleagues, and I immediately saw the value of the interaction with a fantastic up-and-coming developing world like India. Very similar to what we've got in South Africa. And I think we can draw parallels between our two countries, except that everything you do is about 1,000 times bigger than what we are doing because of the number of people and really the success stories you've got over there. So I work here at this hospital, Groote Schuur Hospital. Let me just do the advance. It doesn't seem to advance on my side, Paul. The slide, just to advance it. Has it advanced on your side? I'm just going out. We just, our advanced stop share. If they can make me in control, your technical people put me in control of the screen, then I can do that. Just 1 second.
Just go back to the original.
Okay, that's good. Okay, let's try again. So I work here at Groote Schuur Hospital, the one on the left, and if you think 1967, the first heart transplant Christian Barnard did right under that tower on top of the old building. We now have a new building connected to this old building and where we perform our daily services. The hospital on the right is the Red Cross Children's War Memorial Hospital, and that's been there since after the Second World War, and all our pediatric work are being done there. And it's really a privilege to work in this institution at these hospitals. Our Department of Anesthesia and Perioperative Medicine consists of about 110 members, made up of half of them trainees and half of them specialists. And it's a medical training, anesthesia training department, like in general, like probably I would guess Manipal is. I visited Manipal in early 2000s, and I was impressed with the level of anesthetists it produces. Now, we are also specializing in certain subspecialties, but today I'm going to make an effort to try and introduce you to the value, why our people are using point-of-care ultrasound in our day-to-day practice to improve the outcomes of the perioperative outcomes of our patients. Now, I'm going to start just with a little bit on equipment. Point of care and lung ultrasound is all going together, whether it's transthoracic or the lung, and we use different types of transducers for the different needs that we need ultrasound for. So point of care echocardiography, we will use the phased array, and you can see the frequency of those transducers. That's the cardiac probe at the top right. Then point of care lung ultrasound, curvilinear, and also the abdominal ultrasound. We may use the curvilinear transducer, a bit of a higher frequency. And then vascular access, we will use the linear probe with a higher frequency. And the reason is that there is a trade-off. When you use a higher frequency transducer, the ultrasound signal does not travel that far through the tissue. So you can imagine the heart is further away from a vascular structure, maybe in the pulse when you scan to put an arterial line or a central line in the neck. And we use the transducers for what they are, the need is on the specific time. Now, I have to give credit to Professor Erik Sloth from Aarhus, Denmark, who is also a good friend, and some of you may have seen him at Indian ACTA meetings or other meetings. He's been all over the world talking about point-of-care ultrasound, and he says it's not there to replace a clinical examination. No, it's there to, when you look at all these special investigations that we need to investigate a patient who is critically ill, point-of-care ultrasound is the tool that we take to the patient. It's the tool that we hold in our hand and take to the bedside, and we connect it. It's an extension of our clinical examination. It does not replace all the special investigations, and definitely not transthoracic echo. So we work very closely, just a word of caution, we work very closely with our cardiologists. We learn a lot from our cardiologists. We are not a threat to the cardiology practice. No, we are complementing them. So people are picking up pathology in the operating theater, which was not expected. And this is how we're going to demonstrate, and I'm going to use this presentation as an introduction, and then we'll see how we use a few examples. Now, if you see point-of-care ultrasound as a spectrum, you can take it in a temporal spectrum, so pre-operative, intraoperative, and post-operative, and everywhere it has value. So pre-operative, the patient may present with a normal cardiovascular hemodynamics. Intraoperative, there's a big insult maybe, or an injury to the heart or the vasculature, and therefore intraop and post-operative, it may be totally different from what you start off in the preoperative patient. And we can do this when we can also draw a spectrum with a type of expertise we have. So if you put FATE, or focused assessed transthoracic echo, as Erik Sloth mentions it, or focus, or emergency echo, or non-cardiac echo on the one side, and you put the advanced ultrasound on the other side, where you may need a very specialized operator. Maybe if your institution are regularly involved in mitral valve repairs, or TAVIs, or the MitraClip interventions in the cath lab, then you'll be extremely good at it. But it is not expected that everyone will have that expertise, only if you're using it. So in between comes the spectrum of in-between point of care ultrasound, where you use it as a monitor, either in theater, in the pre-op assessment clinic, or afterwards in ICU. Then, of course, with cardiac surgery, we will use transthoracic and or transesophageal ultrasound. Also in vascular surgery or any high-end, high-risk surgery. We can introduce 3D echo at that stage. We can talk about tissue Doppler imaging or myocardial deformation quantification. All of that are special skills that we will use, and is not necessary. Remember that 90%, 95% of the value that echo brings to our patient happens in the point of care. Yes or no answer. It happens where you detect something that was not discovered before, some pathology. And there again, I give credit to Erik, who has come up with this publication in 2004, and probably one of the first point of care publications. He talked about a directed hemodynamic assessment and the use of transthoracic echo. He said it's not replacing, but it's an extension of your clinical examination. And it may be a monitor even, because things may change during the procedure or the intervention. It is directed at a very specific clinical question. So it's yes or no. Is the heart empty or is it full? Is there a pericardial effusion? Yes or no. Is the heart failing? Yes or no. Is it dilated? Is it hypertrophic? Is there a wall motion abnormality? And there you need different varying levels of expertise to diagnose advanced pathology. But it's very easy to diagnose simple pathology, like an empty or a full ventricle. And we'll show you, demonstrate that later on during this session. It is very, of course, operator dependent. But where do you start? When is an operator accredited or good at what he's doing? We'll talk about that. Nowadays, with the introduction of the small handheld, this is the V-scan. It comes from GE. That was the first of the small handheld machines, but now we've got it from all the vendors, these smaller machines, and lots of others who are not mainstream industry who have come up with this, and people are using it all. So the genie is out of the bottle. It is now not just in the remit of the cardiologist, no. Anesthetist, intensivist, pulmonologist, you name it. Those people, critical care specialists, or just pre-assessment doctors will use this, and you can take it to outside of a specialized unit if you've got an operator who is skilled. By the way, Eric came up with these cards, and some of you may have seen it. It is there for a download on his website. You can go and search for it. It's free to download, and it's wonderful if you want to go through step by step on the FATE protocol and how to get it. Now, since then, many different protocols and people have come up. I'm just talking about FAST, which comes from the trauma fraternity. Feel and Fear, emergency doctors and resuscitation. Raoul Breitkreutz and friends. Focus, the Americans, but see, 2010 they come out and they introduce and they realize that the Europeans have really made big inroads into this point of care echo, and they have to step up, and now it becomes a turf almost. The heart scan from Colin Royce and friends in Melbourne in Australia, and everyone more or less come up with the same protocol. Since then, there are many of these abbreviations, FICE, FREE, FAF. You can just imagine anything with an F, and people put it to point of care ultrasound. So it doesn't really matter. It is all an extension of your clinical examination, and it does not replace a cardiologist. So this was the heart scan and a publication with it from Colin Royce. All of the guidelines are more or less the same. It's all operator dependent. You all have to learn and practice it to get better. There's a learning curve. None of it is a comprehensive echo examination, but you can answer a very directed question very easily. There's FAST, coming from the trauma doctors. And again, it's got its people, the trauma speciality are doing their own courses and running their own protocols in their specific practice. Then Fear and Feel, I've mentioned Raoul Breitkreutz from Germany, who sort of pushed the emergency and advanced life support use of and how to do it. Then Focus from the Americas and their enthusiasts there. Professor Alicia Dennis came from Melbourne, and we were privileged. She spent a bit of time with us. The introduction of transthoracic echo in the obstetric anesthesia and obstetric critical illness. And we're privileged that Mattis and some members of our department have published on this with Professor Dennis, who's really a big endorser of this skill in the in the obstetric field. There you go. Professor Dennis, Professor Rob Dyer, and Matt Gibbs certainly have been pushing the limits since the early 2010s. I've been privileged to be involved in the Critical Care Society and the introduction of echo in the critically ill patient. And it's just to give you a bit of a history when the Critical Care Society, the British Society of Echocardiography, and ACTA, the Association of Cardiothoracic Anaesthetists, got together in the sort of middle 2000s and realizing that this is now hugely important and trying to set up an accreditation process for ultrasound. The first pilot study in October 2010, and at that time I was part of setting this exam, but I thought it was driven by a group of people, different specialities, and I thought I have to sit it too. So I sat that exam too, and it was really an eye-opener to see how this can have an impact on these different specialties. Suddenly we're away from just cardiology, we're across disciplines. It is you taking this tool to the critically ill patient. The first BSE Intensive Care Society examination was in 2012, and since then it's been ongoing. Then came the enthusiasm big time, and all of these people on this paper have been big enthusiasts who have been pushing for this. So one focus is almost like a religious movement of ultrasound. People have been scanning everything, eyeballs, the heart, the big toe, you mention it, and people will be putting an echo ultrasound probe on that part of the body. And so it has started to find its place. And a lot has been published since. Emergency echocardiography then came from the cardiovascular medicine fraternity. So if you look at the authors on this paper, I know Sasha Neskovich very, very well, and most of the authors there. Now, there is not one anesthetist on there. This came out in 2013. This is after Eric has been for 20 years been pushing it and trying to introduce it. So there's, by the way, Fabio Guaracino, I correct myself, is an anesthetist and the present president of IACTA. So it is hugely important that they then realize that this tool is available to non-cardiologists, and they have to have a statement around it. And very interesting, when you look at the publications which followed and came from the same group, they say there is a trend of rapidly growing use of echocardiography in emergency settings by non-cardiologists or cardiologists without specific expertise. We are also witnessing an evolving trend of using cardiac ultrasound examination as a bedside, point of care diagnostic test in emergency settings. Examination, name, focused cardiac ultrasound or focus. Now, they're making that statement almost as if it's a sin to have a probe in your hand. I want to say, it is not like that anymore. We're working very closely with our cardiologists, and in most places around the world, people are doing, and anesthetists are involved. Let me also say that the more you go towards developing countries, like our own country, the more you go outside of big centers of expertise, where you've got a group of cardiologists in a department where they can easily provide a service. The more you leave this and go to the rural areas and the countryside and the smaller hospitals, district general hospitals, the more valuable this tool becomes. That is very important. So in the developing world, the use of ultrasound by a doctor, any doctor, is better than not using it at all. You need the on-off button, you need the basics, you need a training course, and you need to know your own limitations. You are not a cardiologist, you're not replacing that. But if you see something, then it's important. They say a fool with a stethoscope is also a fool with an echo probe. So if you can use a stethoscope wisely, It doesn't mean you're going to diagnose everything with your stethoscope, but then you can use, you've got insight to use a transducer and an ultrasound machine wisely. And it's about knowing your limitations. So we talk about competence and standards all the time when we talk about accreditation. And this thing about competence, they say, oh, it's used as a guard term or a rhetorical trump card, regularly played as the last word in debates about how health professionals should function. So they say, ooh, can't use it because you don't have accreditation. No, you should start something somewhere before you get accreditation. So there's basically a time-based curriculum versus a competency-based education. And it depends where you are learning, what your exposure is. If you connect yourself to somebody who's proficient, then you can become very, very good. Of course, we all want to have a certificate and a qualification in the end, and that's what we're aiming for. So we know about this training pyramid, and I'm going to go back many, many years in the history to Michael Cahalan. We use the words when expertly used. And Professor Jack Shainwise, also from the States. And these were gurus who introduced transesophageal echo into the cardiac practice, cardiothoracic surgical practice. And also early on, he said, perform a complete examination. So when you listen to those people and you try, you're going to learn. And you're going to start with focused ultrasound right here, whether it's transthoracic or transesophageal, and you're moving to the top where you become a real trained operator and an expert who can teach other people. I want to just say a few words about transthoracic and transesophageal. Today's presentation is not about transesophageal echocardiography, but the TOE is just a different window. Anaesthetists, and especially cardiac anaesthetists, often learn their trade of ultrasound through the transesophageal route, while cardiologists or emergency doctors or young doctors who have not had cardiac training will learn through the transthoracic route. And nowadays, every critical care unit, ICU, emergency room, front room, has got an ultrasound machine and a probe. And it depends where you are coming from, how you will learn. And at the end, it's just a different view you are looking at, a different window you are looking at. So it's whether it's the esophagus or the chest, you recognize a pattern. And you must know what a mitral valve looks like, what an aortic valve looks like, and what a left and right ventricle looks like. And then you start to recognize those structures the same way as you would recognize a chest x-ray or an ECG, and you learn to interpret those special investigations. So TOE is really complementing transthoracic echo, and that's all I want to say on this topic. People have looked at this and how much in a critical care unit, often, transthoracic echo is difficult to get a good window. Why? Because the patient's got pleural effusions, pericardial effusions, tamponade, dressings on the chest, wires of electrodes and ECG wires. So it's sometimes difficult. It's more difficult to turn a patient on his left side to perform the investigation. So there is no doubt that transesophageal gives you a crystal clear picture, but you need to have some sort of experience to how to put a probe down and how to, it doesn't come without its risks. So I'm going to start now. I hope you can see this image move. This was taken with a V scan from GE, and that is just a lung with a pleural effusion. You put that on the chest of a patient, and this patient, if he's hemodynamically compromised, needs a chest drain to drain that pleural effusion. Very easy. When you see that type of tiger claw, then you know there's about 500 mils of fluid in that patient's pleural cavity, and it needs to be drained. No point in adjusting the critical care settings of your ventilator because the lung will not expand and get rid of the atelectasis unless you drain that effusion. Now, I'm just going to say another word on guidelines and indications for ultrasound. Many have come and gone. People have published widely on when should you use it, when should you not use it, when is it a risk. at the end of the day, the sicker the patient, the more important the information it provides. And we can almost, at the top, number 1 point, bullet point on every one of these lists, is when the patient is hemodynamically unstable. Then the value of ultrasound is huge, and it tells us a lot. I'm not going to go through the rest of the list because that's specific to transesophageal echo, but whether you have TTE or TOE, hemodynamically unstable patient, it's valuable. Now, transesophageal echo, again, there's been a point of care, a statement by the SCA to come up with a point of care. So abbreviated transesophageal echo examination. You may remember or recall that in 1998-99, Professor Jack Shainwise came out with the 20 views, and some of you may have learned it or studied it, but there are a few basic views with transesophageal echo where you get the maximum hit for your buck, or what do we say, the maximum yield for your examination. That's not what we're going to focus on. How should I use point of care in my daily practice, and how can I incorporate it? We will talk about it again over the rest of the session. Just to say, Dave Canty works with Colin Royce, he's a good colleague and friend, and they've done, in 2012, they've published this paper where what is the impact? How does it make a difference? But remember, it is very difficult to judge the impact of a monitor. So when you use ultrasound as a monitor, it can be incredibly valuable. Just give some volume, or you don't need more volume. But if you use it as a diagnostic tool in the high end, it can be more complicated. But there can be easy diagnosis, which you can make. They've used it in the pre-operative clinic, and they said one of the most important values of transthoracic echo in the pre-op clinic, pre-assessment clinic, is reassuring negative findings. So Matt Gibbs is working in our pre-assessment clinic, and he will tell you all about it later. They would see the elderly patients for hip replacement. The patient comes around and the patient is frail, and there may be crepitations in the lung. They put a probe on the chest and say, no, this patient is not in cardiac failure. That is hugely valuable, because tomorrow or in 2-3 days' time, the patient can go for the operation without waiting for a 6-month referral waiting list to cardiology to get an ultrasound. They also do the 6-minute walk test in the pre-assessment clinic, and therefore can say this patient is cleared for anesthesia, and the decision is being made by an anesthetist who understands the nuances of intraoperative challenge. So they looked at cost effectiveness, cost benefit, and again, the value. It's very difficult to put a monetary value to what a tool will bring to a patient. I mean, the managers will always ask you, but how is it going to save us money? Now, you can say the cancellations have been prevented. We did not cancel this and this and this patient. That would be a very good study to do, Matt, if we look in future. So how many patients did you delay or cancel from their operation next time? And that will be a valuable money-wise, you know, how much does it cost type of thing. I've mentioned the guidelines of, remember we distinguish between an intraoperative monitor versus a diagnostic tool. Diagnostic tool, you may need high-end skills if you want to do detailed quantification of pathology. However, an intraop monitor, I can show you in one afternoon what an empty or a full over-dilated left ventricle looks like, and you can say, well, this one is overfull, dilated, or empty. Let's give volume. And that value is incredible. Just an example. These two examples, the one on the left and the patient one on the right, total different pathologies. But the one on the left can do with a bit of relaxation and filling of volume and slowing of the heart. The one on the right, so the one on the left is a patient with concentric cardiomyopathy. There's almost no volume inside this ventricle. You see the kissing of the papillary muscles and the concentric hypertrophy, increase in muscle mass of that left ventricle. And you don't need an expert to realize that that patient is in trouble. Now that can be given, that type of ventricle can be caused by aortic stenosis, hypertrophic obstructive cardiomyopathy, or other types of congenital problems. Essential hypertension can give you a concentric hypertrophy like that. Well, the one on the right is a patient with non-compaction of the left ventricle. You see all the trabeculations in the left ventricle. The heart is dilated. The wall is not thickening. There is global impairment of that left ventricle. That patient will use totally different strategy if that patient is hemodynamic unstable. That patient will need an inotrope, and a vasoconstrictor, and maybe looking or carefully guiding the coronary perfusion pressure. Now that patient on the right can be a patient with severe preeclampsia, can be which we see a lot of in our obstetric practice, can be a patient with peripartum cardiomyopathy. We never know when this can appear, and the treatment is very specific. How are you going to manage that patient? Okay, so the question is it absent or not? This was performed in our anesthetic room before a patient came for a VASCATH urgent procedure. The patient's in renal failure, young patient, reported in the past to have good ventricular function, but then picked up the patient, the anesthetist couldn't hear the heart sounds and couldn't feel a pulse very well, and said, but why is it like that? Put a probe on, and there's a huge pericardial effusion. So the transthoracic 4-chamber view, with on the left bottom of your screen, you see the right atrium collapsing during diastole. The right ventricle at the top left of your screen also clearly collapses during diastole, and therefore this patient will have a very high pulmonary capillary wedge pressure, a very high CVP reaching up to 20 maybe even, and a wedge pressure of 20, 25. But it's not that it's failing or overloaded. The impact is from outside the compression, the fluid outside of the heart compressing and impairing the filling of that ventricle. And the picture on the right is the short axis of that. It's a transthoracic apical short axis. And again, not apical, parasternal short axis of that same heart. And we appreciate the pericardial effusion around. So immediately you know this patient needs drainage of that fluid to have a good hemodynamics. How did we go about? We started educating and training our people in the early, in 2012, 13, started running courses, not only for our faculty, and I'm very proud to say that our consultants, especially the younger ones coming through, are all very proficient in holding the transthoracic probe. And it's at different levels. I mean, Matt Gibbs himself, who you'll see afterwards, is running courses himself, together with other colleagues in our department. There are several people who can run these point-of-care courses, but Matt at the moment is supervising and leading this program. And we try and get all our new people in the department to go through this. The same for our new registrars, our residents coming through. All of them now, where 10 years ago, they may have to do a course to be proficient with this. Now they all come in, and depending on who they work with on the day, the machine is in theater and they will be using it. It is hugely valuable, and the people are hungry to learn. And I'm very proud of that. Although these point-of-care ultrasound courses are very nice, concise, one-day course, actually the real way you are learning is the way Dr. Robert Munsey has learned, is by using it on a regular basis during their training time. And I want to demonstrate to you how that happens. We've also come up with a few other ideas. Matt started this Fate Federation, which is just a little WhatsApp group for our department, and every Friday he's been teaching people on whether it's on the simulator, on one of the residents taking a shirt off and they scan the person, and so on and so on. It's just holding the probe, understanding the on-off button, the settings on the dashboard of the machine, and the knobology. Then we have very proud about our sonographer in our department. We've appointed a sonographer, and she's really one of the stalwarts in the department. And usually on a Tuesday or whatever day she's coming in, then we are the first registrar that can get hold of her will grab and take her to the theater, and their sole purpose for that day is to train someone. And usually somebody has claimed her, then it's very difficult to give her up. And people just learn, and the learning program, the learning curve is exponential, really. And then we've got WhatsApp groups where we post interesting cases. I'll give you a few examples of how it works. And with that, it actually is telemedicine made easy. People are learning. Of course, there's confidentiality of the patient involved, but people are learning very quickly by sharing their difficult case of the day, and they share to other registrars. And whether you're a senior person or a young person, you look at the picture, and usually there's a question connected to the picture or the video. That nowadays you can take a video with your cell phone of the screen of the machine and put it on WhatsApp. And as long as you don't identify the patient, or everyone is learning, and we're all appreciating the activity is so much more. We've started with this point of care ultrasound medical students program, where 4th year we get medical students and 6th year. And then we try and do on a regular basis these courses. Lenore Naidu, who is our in-house sonographer in the department, is very switched on and very advanced with both adult and congenital cardiology and scanning, and very keen on teaching and involved in these courses. So we've got this type of manual we've put together with the help of Eric, and we are now trying to train our medical students on a regular basis. I'm going to stop there. I suspect I haven't kept an eye on the time, but I suspect it's about 40 minutes now. Dr. Manju, I'm happy to take questions now, or if you want to stop, interrupt, then we can catch up in 10 minutes, 12 minutes time when we start again. I want to stop by saying education is not the filling of a pail, but the lighting of a fire. We need to install this keenness with our young doctors. It's our duty to say, go for it. I'm not so good at it, but the people to follow, they must be experts on this. And I would like to think and believe that our trainees, my trainee, my registrar who starts today will be a better product than what I am today. If I don't achieve that, then I have not achieved my goal. So the day I go, everyone in the department must be better and more expert than I am. So let's share information, share this, and we promise to do that with the next part of the session. I'm going to stop sharing now.
Thank you, sir. So we'll be taking up the questions at the end of both your sessions, sir.
Thank you very much, and I'm happy with that. You tell us when we will stay on Zoom. You tell us when you want us to come back and follow with our next presentation.
Sure, sir. Thank you, sir, for this comprehensive session. We will now proceed to take a short break, and we'll resume the session after the podium presentation. Kindly post your queries and comments in the comment section on your screens, which will be answered at the end by our speaker. Moving on to the podium presentation, Dr. Reshmi and Dr. Sumuk from Kasturba Medical College, Manipal, will be presenting their work, and this will be moderated by our own Dr. Ramkumar Venkateshwaran.
Invite Dr. Rashmi to present her paper.
Good evening, sir. Title of my study is Comparing the Efficacy of Low-Dose Intravenous Ketamine versus intravenous paracetamol in alleviating pain due to propofol injection during induction of general anesthesia. It's prospective observational study. Introduction. Propofol is of choice anesthesia, total intravenous anesthesia, sedation in ICU, maintenance of anesthesia. Coming on to the study drugs, ketamine, it's an NMDA receptor antagonist, uses induction of anesthesia, analgesia, bronchodilator, sole anesthetic for short procedures. Paracetamol inhibits cyclooxygenase in vascular endothelium and blocks bradykinin-sensitive chemoreceptors. Uses antipyretic and analgesic. Aim and objectives. Aim of my study is to compare the efficacy of intravenous ketamine 0.5 mg per kg versus intravenous paracetamol 2 mg per kg in attenuating due to propofol during induction of general anesthesia. My primary objective is to compare the efficacy of both drugs in alleviating pain due to propofol injection at 0, 1 and 2 minutes after injection using the verbal rating scale. Secondary objective, to evaluate the hemodynamic changes before and after administration of both drugs until intubation. Materials and methods, it's a prospective observational study, CTRA registered, sample size of 300. Inclusion criteria, ASA 1 or 2, 18 to 65 years of age group, underwent elective surgeries under GA. Exclusion criteria, allergy to study drugs, history of analgesic abuse, emergency surgeries, and contraindications to ketamine administration. Methodology, 20 gauge IV axis secured in dorsum of hand and fluid starter. Tourniquet was tied on the forearm to occlude venous blood for 60 seconds. Patients enrolled received either ketamine or paracetamol. After 1 minute, tourniquet was released and 1/3 of the induction dose of propofol was administered over 10 seconds. Pain score was assessed on verbal rating scale of 0, 1 and 2 minutes after administration of 1/3 dose of propofol. Hemodynamic parameters, heart rate and blood pressure were also documented at specified intervals. Results of my study, table 1 showing verbal rating scale at 0 minute, table 2 at 1 minute, table 3 at 2 minutes with 150 patients in each group, and it was statistically significant. Table 4 showing heart rate, beats per minute. Table 5 mean arterial pressure in millimeters of mercury with specified time intervals of pre-induction 0 minute, 1 minute, 2 minutes and after induction and after intubation with patients of 150 in each group, and both the groups were comparable. Discussion and conclusion. Pain and injection of IV drugs may be distressing to the patients and can reduce the acceptability of an otherwise useful agent. Pre-treatment with intravenous ketamine at dose of 0.5 mg per kg is effective in reducing pain due to propofol injection compared to intravenous paracetamol at dose of 2 mg per kg without any hemodynamic consequences. These are my references.
Okay. Right, Dr. Rashmi. Can you hear me, Rashmi?
Thank you, sir.
You can hear me, can't you?
Yes, sir.
Yeah, that was an interesting study by you and Dr. Shaji. And thank you for that very crisp presentation. I did have a few questions. You had mentioned that you are using a forearm tourniquet. Did you just apply a kind of a rubber tourniquet, or did you use the BP cuff as a tourniquet?
No, sir. The tourniquet which used for taking blood samples, the black tourniquet we used.
Okay.
Yes, sir.
Now, do you know that when you apply a tourniquet on the forearm where there are 2 bones versus applying a tourniquet over the arm where there's only 1 bone, do you know there's any difference in because your objective was to occlude the venous circulation? Yes. Which of these would be more effective?
In the
Tourniquet over the
arms,
arm or the forearm? In the arm, is it?
in the arm will be better because it has a long bone and the pressure will be adequate
Right.
seal will be there.
Good. So that's the point I was coming to, Rashmi. So why did you choose to use the forearm? Because there can be some escape of the drug between the
Yes, sir.
the radius and the ulna. Did you think of that,
Yes.
or can you tell me why you chose the forearm despite this problem?
We actually didn't think about that, sir. But previous study we have compared in the forearm, so we thought we will also go ahead with forearm.
Okay, right. And because the thing is, did you expect this to act by systemic action or local action? Ketamine or paracetamol, you expected it as a local action or as a systemic action?
Ketamine basically is a local action. Paracetamol, it has a local as well as central action, sir.
Right. So that makes it very important then. So if you allow some of the drug to escape below the tourniquet, then the pre-treatment that you have given may not be as effective. Okay, that's something that you need to keep in mind. But other than that, I think it was a very good study. You used 0.5 milligram per kilo of ketamine, and you were able to communicate with your patient at that level.
Yes,
all of them were communicating, right?
Communicate.
And your 4-point scale, was it described to the patient? 0, 1, 2, and 3. The 4-point scale, did you give any explanation, or they were just asked to mark one of the 4? When you say
no, sir. 0 means no pain. 1, only pain reported only on questioning. 2 will be with some, yes, sir.
I got it. So it would have been a good idea for you to put it on the slide as well, okay? So that whoever is listening to your presentation would understand what exactly we use. Good.
Yes.
I think it's a very nice study, very simple and well executed. Okay. Thank you for the presentation, and inform Dr. Shahaji also. Thank you.
Thank you, sir. Thank you so much.
This paper will be presented by Dr. Sumukh. I invite Dr. Sumukh to make his presentation.
Good evening, sir. The topic that I'm going to present is ultrasound-guided lower limb blocks for orthopedic procedure in a patient with chronic liver disease. My guide is Dr. Ishwar. Coming to the introduction, patients with end-stage liver disease are at significant risk of morbidity and mortality after anesthesia and surgery. Any medical or surgical interventions may exacerbate liver dysfunction and result in life-threatening hepatic failure. The Pew modification of Child's classification is used to estimate the risk of mortality in patients with liver disease undergoing surgery. In Child's class C, a total score of 10 to 15 carries a high risk of more than 50% perioperative morbidity and mortality. Other predictors of poor outcome in these patients include malnutrition, emergency surgery, sepsis, and blood loss. Fascia iliaca compartment block is administered for surgeries of the anteromedial and the lateral aspects of the thigh. Sciatic nerve block results in anesthesia of the posterior aspect of the thigh and leg, but sparing the medial aspect, the saphenous aspect, which will be blocked in the fascia iliaca compartment block. Coming to the case history, this is a 60-year-old male with decompensated chronic liver disease with portal hypertension, esophageal varices, and gross ascites, posted for open reduction and internal fixation of the distal femur fracture on the lateral aspect. Patient had undergone preoperative ascitic fluid tapping thrice. When patient was risk stratified according to Child-Pew classification, he came in the category C. Preoperative investigations revealed a hemoglobin of 10 grams per deciliter, anemia, and low platelet count of 75,000 per millimeter cube, thus ruling out the use of spinal anesthesia for this patient. Materials and methods. Ultrasound-guided fascia iliaca compartment block with sciatic nerve block was planned for him pre-op. The images of the ultrasound are shown in the picture below. A total of 50 ml was used with 25 ml of 2% lignocaine with adrenaline and 0.5% levobupivacaine. And this was the same mixture was used for the fascia iliaca compartment block and the sciatic nerve block. And also patient was given sedation of IV dexmedetomidine throughout the procedure in a dose of 0.3 micrograms per kg per hour. As we can see in the images here, this is the subgluteal approach to the sciatic nerve block. This is the ischial tuberosity seen in the ultrasound, and this is a greater trochanter. This image is gotten by a curvilinear probe, 5 megahertz, and we can visualize the sciatic nerve in the region in the midpoint between the two, below the gluteus maximus and above the quadratus femoris muscle. This is the fascia iliaca compartment block, wherein the probe is kept, the linear probe is kept at the inguinal crease, and after visualizing the facial artery, we move laterally and we visualize the iliacus muscle, and the fascia above that is the fascia iliaca, and our aim is to deposit the anesthetic below the fascia iliaca. And this is a volume block, so a large volume will most of the time will definitely block the femoral nerve, and most of the time, up to 80% of the time, will block the lateral cutaneous nerve of the thigh. In a case of liver disease, only elective surgeries should be planned in a well-compensated liver disease. In use of inhalational anesthetics, and because of the altered physiological state in these patients, inhalational anesthetics, sedative hypnotics have altered metabolism in decompensated liver disease. Wherever possible, we would prefer to use regional anesthesia after ruling out coagulation abnormalities. Local anesthetic metabolism, though altered, but can be safely used after calculating the toxicity dose. Using an ultrasound is a more foolproof way of performing block, and you can decrease the volume as well as ensure the block is acting better.
We finished your presentation, Sumukh?
Yes, sir.
Okay, good. I think this is a very challenging case that you and Ishwar have shared with all of us. It's a very interesting case that you presented. I did have a, can you go back one slide where you've listed, some of the problems in these patients, and the fourth bullet point talks about local anesthetic toxicity. So I was a little concerned. I could not figure out what's the total dose of local anesthetic that you used. If you can go back a couple of slides, I think you used 50 ml of a solution total for the two blocks. Yes. And so what was the final concentration of lignocaine and the final concentration of levobupivacaine, and how much of adrenaline was there? Was it the classic 1 in 200,000?
Yes, sir. With the
how did you prepare the solution? So otherwise, your case management is perfect. I think you've done a very good job. What is the position in which the patient was operated?
Sir, the position was supine, sir.
Supine only, right? Okay. So now you just explain this, the local anesthetic composition to me, because I just want to know how you made sure that you restricted yourself to within the toxic limits.
Yes, sir.
Incidentally, I don't know the weight of this patient. You were not mentioned.
Yes, sir. Patient was around 70 kg, sir.
Okay. So tell me how you calculated the.
Yes, sir. With the use of 25 ml each of lignocaine and levobupivacaine, sir. When we combine the two, the concentration of each halves. So 2% lignocaine with 1:2 lakh adrenaline becomes 1% lignocaine with 1:4 lakh adrenaline. Right. And levobupivacaine 0.5% becomes 0.25%, sir.
I got that. So now that's the reason why I was confused with the way you put on the slide. This is misleading. Would you agree, or is it clear what you're trying to say? Because this appears that you've used it's a 25 ml of a total solution. You could have probably labeled it as 1% lignocaine. And how did you make up the adrenaline to come up to that concentration of 1 in 200,000? Did you add more adrenaline?
Sir, we used a prepared formula, sir. The
Okay.
1:2 lakh adrenaline.
That comes along with the lignocaine, right?
Lignocaine, sir.
What about levobupivacaine? Does that come with the adrenaline also?
No, sir.
No.
That is plain.
Right. So it gets diluted, right?
Yes,
so
sir.
This is the only confusing point in your presentation, right? And that is the important point because you made a mention of it. Local anesthetic toxicity is definitely an issue, and you have to keep it in mind when you use large. So you're given a fairly large volume, which is okay for these two blocks, but you still have to convince me that you have restricted yourself to the total. So totally you used 500 milligrams of lignocaine.
Yes, sir.
For the two blocks together, and you have used 2.5 times 25, about 62 milligrams of levobupivacaine. Right. So you're saying that comes within the safe limit. Okay, now I can understand, but not as you have presented. Do you understand my confusion?
Yes, sir.
Good. Now, if you you were lucky, you got a very good block, and your dexmedetomidine also produced enough sedation. Did you give a loading dose of dexmedetomidine, or you started straight away with a fluid infusion?
No, sir. That initial loading dose of 1 microgram per kg in the first 10 minutes that we decided not to go with, sir. Instead, we just started the infusion, and by the time the surgery.
Sumukh, what was the reason behind that?
Sir, we wanted to minimize the number of drugs we gave, sir. So we thought just.
Good. I think it's a very challenging case, well managed, and thank you for the clarification. Okay. Thank you so much. And convey my thanks to Ishwar as well.
Thank you, sir.
Thank you.
Thank you, Dr. Ramkumar, Dr. Reshmi, and Dr. Sumukh. We will now resume the workshop. Over to you, Dr. Swanevelder.
Is it? Can you hear us? Are they controlling our video? You are controlling our video.
We can hear you, yes.
I think your video, the host has stopped our video. So if you can just switch our video on again, please.
So we're not controlling the video, so could you check the settings?
Okay, let's just get that. Maybe do you want to go up? No, we're not going out. Yeah, something is happening. Okay. Almost there. Okay,
So we've got the video on now. Thank you.
Can you see me? Can you see me?
Yes, we can.
And next to me on my left side, so thank you very much for the technical help here. We're back from Cape Town in our department at Groote Schuur Hospital. I want to introduce Dr. Robert Munzi. And the reason why I've asked him to speak is because I've just noticed that your people are also required to do some research. And that is certainly one of the requirements of our own MEd trainees or our college candidates. When people become a specialist, they have to have a research component. Now, Dr. Munzi is in his final year as a resident or registrar, and I want to show you how people are learning from each other and training each other. So he did his research on a topic which he will explain to you now exactly what he's done, but just to prove the value of point-of-care ultrasound in the perioperative setting. Robbie, all yours. Share your screen. you're at the last slide. Just go to the first slide. Excellent.
Cool. Thanks, Prof, for the introduction. Good afternoon, everyone. My name is Robbie Manzi, and I will be presenting to you on my Master's in Medicine research study entitled PULSE, or Perioperative Ultrasound in Emergency Surgery, along with Dr. Matthew Gibbs, who is my supervisor on my project, who you will meet a bit later. We looked at the use of perioperative ultrasound, or POCUS, specifically in patients presenting for emergency surgery at Transthoracic Hospital. So at the top, you can see where we are presenting from at the moment, which is Transthoracic Hospital, which is overlooked by one of the new 7 wonders of the natural world, Table Mountain. And this same mountain overlooks another famous Cape Town landmark called Newlands Cricket Stadium. And interestingly enough, the first ever ODI, or One Day International, played at this venue was between South Africa and India in 1992, which I'm glad to say that South Africa went on to win by 6 wickets. I just thought that would be a nice way to make friends with my Indian audience. So just a bit of background. The focused assessed transthoracic echo, or FATE protocol, was developed by Eric Sloth and is well established and used widely around the world. It aims to help the clinician in making a diagnosis or to confirm a clinical suspicion as quickly and efficiently as possible, and to help guide effective treatment strategies. The first question I set on to answer was, is there any evidence that POCUS changes perioperative management? And the answer is yes. A study done in high-risk cardiac patients seen in a pre-operative clinic showed that a POCUS scan changed the management of 54% of patients. And in 2 studies that scanned patients presenting for emergency surgery in a high-income country, there was a 43% and 44% change in perioperative management. An added benefit of performing FATE scans is the incidental finding of undiagnosed cardiopulmonary pathology. One study looking at emergency surgeries showed in 20% of cases, additional diagnoses were found. South Africa is classed as an upper middle income country and subsequently has a different patient population, which has public health challenges such as poverty, related illnesses, non-communicable diseases, HIV and related diseases, and a heavy burden of injury and violence. The majority of surgeries performed in South Africa are of an urgent nature, up to 66.4%, and this was shown by the SASOS study, which was published in 2015. So the hypothesis of our study was that performance of point-of-care cardiac and pulmonary ultrasound in patients presenting for emergency surgery in a resource-limited country results in a significant change in anesthetic management. It was a prospective observational study, and we calculated we needed to recruit a total of 62 patients to detect a 20% change in perioperative management. We included any consenting adult patients over the age of 18 that were coming for emergency surgery, and we excluded obstetric and elective cardiothoracic surgery patients. We scanned over a period of 2 weeks in September and October of this year between 7 and 4, and we excluded weekends. So our clinical methods, an anesthetist, either a trainee or consultant, was sent to triage the patient in the ward or before anesthesia in the induction room, and they were then asked to complete a pre-FATE case report form. The FATE scan was then performed on the patient, and these findings were presented to that responsible anesthetist. A post-FATE case report form was then filled in by the responsible anesthetist, and we then compared the 2 forms to see if there was any change in perioperative management. Our primary endpoints were any change in perioperative management, as I mentioned, and these included things such as anesthetic technique, fluid management, any additional monitoring, and up or down referral, for instance, to say critical care or cardiology. Our secondary endpoint was to describe the prevalence of cardiac and pulmonary disease in our patient population. We are in a very fortunate position here at UCT to have adequate access to ultrasound devices that we can use on a daily basis, and we even obtained a loan of a portable Terason 3100 machine for the use during our trial. To maintain validity of our results, we required scans to be done by a certified individual, And this did bring up some challenges because we had to balance clinical service delivery versus acquiring the scans. Although, as has been mentioned, FATE is very quick to do, and scans on average took between 5 to 10 minutes. There is a high turnover of cases in our emergency theatre, so this was another challenge that we had to deal with, and we limited our scanning to daytime hours just to prevent researcher fatigue. So just a quick run through of some of our findings. We performed a total of 67 scans over the 10 days. We had an equal spread of male and female participants with a mean age of 43. Over 50% of our sample group were ASA, or American Society of Anesthesiologists Classification 3, suggesting on the whole, the patients presenting to our institution for emergency surgery have severe systemic disease. The comorbidities most frequently seen were hypertension, uncontrolled diabetes, and known HIV disease. And over 61% of the surgeries were booked with the triage designation of yellow, meaning that the case should be aimed to be done within 6 hours of being booked. On the whole, it was very easy to acquire good images during our scans, and it was only noted that in 8% of patients, it was difficult to obtain good views. Interesting finding was that 32% of our patients were found to be hypovolemic before they came for surgery, and this diagnosis was based on left ventricular volume measured during systole with less than 3 centimeters used to suggest hypovolemia. This was then confirmed with inferior vena cava diameter measurement and presence or absence of IVC collapsibility. 92% of our patients were noted to have normal ejection fractions and MAPSs, and then we found 6 incidental pericardial effusions, the biggest one measuring 1 centimeter. Reassuringly, only 11 patients had abnormal valvular function, and this was with an equal spread between aortic, mitral, and tricuspid valves. And then 5 scans picked up pleural findings, all of which were pleural effusions or hemothoraces. So I just thought I'd highlight 4 scans where we thought that FATE had an influence on perioperative management. So this first scan is from a 27-year-old ASA3 patient, female patient who was booked for uterine evacuation under general anesthesia for query molar pregnancy. She presented with PV bleeding and had a positive pregnancy test. Clinically, the patient was not hypovolemic. The blood pressure was within normal limits and the pulse was 91. She was anemic with a HB of 8.8 and biochemically hyperthyroid. She had been medically managed with neomercazole, Lugol's iodine, and a beta blocker preoperatively, which was then stopped. Our FATE findings showed that the patient was hypovolemic with normal ventricular function, and a pre-induction fluid bolus was then given, as well as blood being ordered to be in theatre. The second scan is of a 32-year-old male patient who was booked for a transesophageal echo plus minus subxiphoid window under general anesthesia. He had a history of 1 isolated precordial stab wound and was referred from a peripheral hospital in a stable condition after an EFAST scan, so an extended focused assessment with sonography for trauma scan, showed a 1 centimeter pericardial effusion. Our FATE scan showed that the patient was euvolemic, that there was good left ventricular function, and that a 0.5 centimeter pericardial effusion was present, which was not causing any right ventricular collapse. Lung ultrasound showed no abnormalities, which was reassuring, and the findings were relayed to the trauma surgeons who decided to continue with the procedure as they had booked. The next scan is of a 34-year-old ASA3 patient who was booked for exploratory laparotomy for a query ectopic pregnancy. The patient gave a history of having 2 previous DVTs and a pulmonary embolus and was previously on warfarin but defaulted her treatment 4 months ago. Clinically, there were no symptoms or signs of a current DVT or pulmonary embolus, but however, the patient had had no further workup done before coming to theatre. Our FATE scan was reassuringly normal and showed no features of right heart enlargement, and the right ventricular function was good, with the TAPSE or tricuspid annular plane systolic excursion of 20 millimeters. Considering the normal scan and the urgent nature of the procedure, the surgery went ahead after discussion with the surgical team. The last scan I'd like to talk about is of a 34-year-old gentleman who was previously well, booked for a left-sided thoracotomy for clear out of a retained hemothorax. The patient had an intercostal drain in situ on the left-hand side, which was not draining any blood anymore, and there was no ICD on the right-hand side. The chest X-ray showed bilateral blunting of the costophrenic angles. Our FATE scan showed a normal functioning heart. However, there was an incidental finding of a 9mm pericardial effusion. Pleural scanning showed a consolidated, organized hemothorax on the left-hand side, but on the right-hand side, you can see in that scan, there was an approximately 470 ml hemothorax visualized. This information was then relayed to the surgical team, and the decision was made to proceed with the surgery. However, a right-sided intercostal drain was then inserted post-induction. So, unfortunately, I can't comment on the primary outcome of our study because we haven't been able to analyze the data fully yet. But what we can take away from doing the study is that performing POCUS in the perioperative setting is feasible in a resource-constrained environment, and that it provides useful information that may influence perioperative management. It can also minimize delay in patient management in whom they would traditionally and have to have waited for formal echocardiography from cardiology. And just those are the references in case anyone would like to have a look at them. Thanks very much.
Thank you very much, Robbie. So the whole point is that you scan these patients, and often they have been starved for a while and they are hypovolemic.
Yeah.
And almost all of our urgent cases or patients coming to theatre, they're all hypovolemic. And remember that we try to be conservative with fluid, but often that is what they need to, that would be a good message. Thank you very much. So next, it gives me great pleasure if we can just get the camera on our next speaker is Dr. Matthew Gibbs, who's one of our senior colleagues, who is the leader, director of our Transthoracic training program. And with him is Dr. Elmar Kruger, who is one of our registrars, and we have convinced him that he must show his chest so that we can scan it. So thank you, Elmar, for that. We're going to try and just maybe on Dr. Gibbs' face, Matt Gibbs' face to start, and he's going to say a few words before he's going to talk to us about the scanning. Thank you, Matt. I'll leave you there.
Thanks for the introduction, Prof. Hi, everyone. It's wonderful too that we can use technology in what's normally very much a hands-on session. Most of our training is in terms of teaching point-of-care echocardiography. It's always one thing to talk about it, it's another to actually practically perform it and actually put your hands on the probe. So this is certainly a different experience, trying to teach echocardiography across 6,000 kilometers. But I hope the combination of the views of the ultrasound machine and how I'm holding the probe will be very enlightening and informative, and that you will hopefully encourage you to learn and to apply these skills in your perioperative practice. It's certainly one of the biggest changes to my perioperative practice in the last 10 years, and I hope you will see the benefit. So Elmar has kindly volunteered at the point of an echo probe to be my victim, my patient. So I was going to go through a very simple scan. When we do point-of-care echo training, we intimidate our colleagues by saying that the day, which is normally a one-day course that we offer, that by the end of it, you should be able to acquire a decent scan, a full echocardiography, or at least a simple point-of-care scan within 2 minutes of beginning your scan. And it sounds very scary, but it's actually very doable once you learn the basics of the procedure. So we're going to start with, which is position 1 on your fate card. You can actually download the fate card off the internet in PDF of usabcd.org. It's all freely available. And we're going to start with the subcostal 4-chamber view. So just a reminder that if we are able to zoom in on the probe, with a traditional phased array probe, it is a low frequency probe, remembering that low frequency penetrates deeper. High frequency probes are used, linear probes are generally used for vascular access, and they only penetrate to a maximum of 6 centimeters or so, depending on the probe. With a phased array, you're going to penetrate deeper to 20, 25 centimeters. I'll talk to you as I go explaining the use of all these complex knobs that you see on the machine behind me. So let's find our anatomy. So just below the xiphoid sternum, there's a space. There is an orientation marker on the side of the probe here. And that orientation marker, in pretty much all the most basic views, points towards the patient's left-hand side. So you need to make sure that it is pointing correctly. So putting on my probe, I start seeing a beating thingy. And it's always good to see a beating thingy in a patient. You can encourage them that they are actually alive. I am busy changing the depths on my machine. Each machine, each manufacturer has a certain way of setting up their machine that's a little confusing as you move between machines. So get used to the machine that you have in your own individual practice, so that it becomes easier and slicker as you more you use it. So I'm using my probe to always have a 3D picture in your mind of where the heart is in the chest. Now you've got apex on the left-hand side of the chest, and your base of your heart is beneath your sternum, and it's lying across the chest. So if you don't aim your probe towards where the heart is, you're not going to see it. So one of the most common problems I see is the probe gets placed directly on the patient's abdomen here, and as we know that the heart is not an abdominal organ, it is more useful to lower the tail. If you notice there, I'm lowering the tail of my probe, looking up to where I expect the heart to see. And now on my screen behind me, I can see the 4 chambers of Elmar's heart. Elmar, can you take a nice deep breath in for me and hold? And you can see that with that deep breath, my image has improved. I changed my depth so that I can see the entirety of the heart. And using my pointer, I should be able to show you on the screen. There's the left ventricle, right atrium, and left atrium with your mitral valve and the tricuspid valve. You can breathe normally. Thank you, Elmar. So this view is a useful view to observe global ventricular function, gross abnormalities in filling, tamponade, large pericardial effusions. It's maybe the only view that you can see in a patient with COPD. Often patients are hyperinflated. It's very difficult to see the rest of use the other views, as traditional parasternal views, because of the hyperinflation. And in fact, with the movement down of the heart due to this hyperinflation, you actually get a really good view from the subxiphy. And we can modify our views such that we can examine for ventricular function in the short axis as well. So this is usually your starting view. In patients that are obese or pregnant, it obviously becomes a lot more difficult. Patients with surgical wounds will have a laparotomy. This obviously becomes more difficult. From this view, what we often like to look at is the inferior vena cava, and it's relatively easy to have a look at. From this position, I rotate the probe 90 degrees so that the orientation marker that I'm pointing to here points directly up towards the ceiling. At that point, I can see on my screen, you can see the liver on the left-hand side. I lift up my tail of the probe, looking back, you see a pulsation of a vessel, a dark black thing there. There must be fluid floating there. The more I move to the left-hand side, the patient's right-hand side, I see another vessel. So I'm going to, what do you call panning the probe. We look back across, I see the aorta, and the patient's more to the patient's right-hand side, see a nice full inferior vena cava. Take a nice deep breath in, Elmar, and breathe all the way out. You can see the variations in intrathoracic pressure results in a change in your preload, which results in an increase and decrease in size in your inferior vena cava. And this is one of the views where you would look at IVC variability. We also know that this is IVC because you can clearly see liver above and below, whereas in the aorta, there is no liver below the aorta. So I'm going to go back to IVC, and you can actually follow your IVC directly into the right. If I look up, I can see it going into the right atrium, right over there. So I know that this must be the inferior vena cava. So moving on from our first position, just a reminder, you can never have enough jelly. I'm going to move to our apical four-chamber view. So remembering, usually I ask the patient to do a feel for the apex. Place the probe such that the orientation marker is pointing again into the patient's left-hand side, to the left axilla. But now I'm orientating it so that my probe is aiming towards the patient's right shoulder. So I'm expecting to look straight up the interventricular septum up towards the base of the heart. So we get, again, a global picture. I'm not getting great views at the moment. So usually it involves a little bit of moving around. And now you can see all four chambers of the heart. So this is an apical four-chamber view. So here's an interventricular septum in the middle of the screen. We're trying to keep it as in the middle of the screen as possible. The left ventricle, right ventricle, right atrium, and the left atrium, with the mitral valve and the tricuspid valves both pointing directly back towards my probe. So this is one of our favorite views, gives us a lot of information, and when we start doing valve evaluation, this is one of the views we use most often, because the flow of the blood is going directly towards the probe. And if you look at, you remember your Doppler equation, you want it to be as parallel to the flow as possible so that you're able to pick up a Doppler shift if you are doing measurements. So this will give us, as you change the angle of your probe, you're going to see different structures. This, I'm holding the probe so that I'm aiming at a more posterior structure. This is a coronary sinus appearing on the screen now. As I lower the back end of my probe and I'm starting to look up, I become a more four-chamber, and the further I look, I start seeing a five-chamber view. And you can see the aortic valve appearing in the middle of the screen there. You can see it next to my arrow with the aortic valve opening and closing. So when we try not to use too many advanced modalities when you're teaching basic point-of-care ultrasound. So I'm going to go through the full exam, and we'll go back to application of some of the other modes, M mode and Doppler. Doppler we try to reserve for more advanced views, but M mode is a useful modality that gives you a lot of information when you are examining and learning. So we're going to move to the parasternal views, which in my book is probably your money shot views that give you the most information in many circumstances. So I'm going to cheat because I really know that my views are going to be improved by this. But when you are struggling to get a good parasternal view, as well as your apical four-chamber, the best thing to do is to ask the patient to turn on the left-hand side. So Elmar, can you do that for me, please? I normally sit right next to the patient. Obviously, in the time of Corona, we would consider using more barrier protection, depending on what sort of exposure you have to COVID-19. So the parasternal views, I'm going to start usually the second or third intercostal space. This is the parasternal long axis view. And if you look at my probe, my orientation marker is pointing directly towards the patient's right shoulder. And you place the probe perpendicularly on the chest. So Elma's got a very nice view. I'm going to adjust my depth of my screen. The reason why I'm going to show you some of the artifacts that you can create by not paying attention to some of the basics of echocardiography. So in this view, we've got a good view of the left atrium over here, mitral valve opening and closing, left ventricle, aortic, the left ventricular outflow tract, aortic valve opening and closing, and yes, that's my point. Okay. The ascending aorta. But if you look at this this image, it looks like Elma's got two hearts. This is called a ghost image, and this is the result of not optimizing your view. So what's happened is that you've got a very strong reflector in your pericardium, and there sets up a reverberation signal between that pericardium and the transducer itself. And the transducer detects the extra reverberations as being twice the distance of what it actually comes from. So you can see that you create a second heart at a depth below that pericardium. And to improve that, I'm going to change my depth. There's a number of benefits to this. You remove that ghost image, plus your frame rate improves and allows you to have a better image and greater clarity of detail when you're examining this patient. So parasternal long axis views gives you a lot of information about movement of the aortic and mitral valves. We're able to work out fractional shortening from this image. We're looking at how well the left ventricle contracts towards each other, as well as the relative size of the left atrium and the left ventricular outflow tract and ascending aorta. And generally speaking, you expect that to be around about the same size. And if you see a ratio of 2:1 with the left atrium, twice the size of the aorta, you can safely say that you have a dilated left atrium. A parasternal short axis view involves a rotation of the probe 90 degrees from that initial view. So I'm going to go back to my parasternal long axis, orientation marker pointing to the patient's right shoulder. I rotate 90 degrees such that the orientation marker is pointing directly to the left shoulder. And you see that I've rotated on the mitral valve, and right in the middle of my picture is the mitral valve opening and closing in the middle of the picture, and I'm cutting through the left ventricle in a short axis. If I move my tail of my probe a little bit towards the right shoulder, I get a mid-papillary short axis view, which is a very useful view in terms of looking for regional wall motion abnormalities, evaluating for pericardial effusions, and the relative size of the right ventricle with the left ventricle. So we're going to see that here on the top left-hand side, you've got the right ventricle, you've got your interventricular septum in the middle, your papillary muscles, and you see that if you put your probe in the middle there, that all areas of the heart are moving equally towards the middle. So there's no sign of regional wall motion abnormalities. There is good function, good movement, and we can safely say that we have a normal examination. There are further and more advanced views that you can use from this position, all involving just moving the tail of the probe further down, which allows us to evaluate the mitral valve in short axis. The more I move, I'll eventually get onto the aortic valve in short axis. You can see a tri-leaflet aortic valve appearing in the middle of the picture, as well as evaluating the tricuspid valve, pulmonary outflow tract, and the left atrium. But these are the more advanced views, which you not necessarily require for more basic point-of-care ultrasound. So those are the four basic views. So subcostal four-chamber, apical four-chamber, parasternal long axis, and parasternal short axis. All right. So I'm now going to move towards, I'm going to always include the pleura. The FATE protocol always lie flat. Is always, the idea is to always evaluate the pleura. So to evaluate for the pleura, patient normally lies supine. Orientation marker always points cephalically up to the patient's shoulder, usually posterior axillary line, and we're going to look for the, there we go, that's better. I'm going to change my depth here again, so it's now a little bit too shallow. I'm not seeing what I'm needing to see. There we go. Okay, all right, so here we've got the spleen in the middle of the picture. On the right-hand side, we see the bright white dome of the diaphragm, and above that is where we expect to see any pleural effusion. If there are other abnormalities like a pneumothorax, you would struggle to see any object whatsoever, because air is such a poor transmitter of ultrasound that most of the image gets lost completely, and you're not able to see anything. So looking on the other side of the patient, again, orientation marker is cephalic. And I'm going to look at the patient's right-hand side, again, posterior axillary line. And we can see a little bit of almost spine at the back here. This is his liver, and with his breathing, you can see the diaphragm moving up and down. And as if you develop a large pleural effusion, what you'll see is that you get a large black pool of inky fluid. As demonstrated, Robbie showed a very nice video of a large hemothorax, and you can see that you develop atelectasis, and you normally see the tip of the lung sort of floating, flapping around in the breeze, so to speak. So when you're doing evaluations, always remember to look at the pleura. Just to briefly mention lung ultrasound. In the days, as we are dealing with corona more and more, lung ultrasound has certain benefits when dealing with the acutely short of breath, and can help you detect major pathology such as pneumothorax, which is quite common in patients with COVID. You're able to pick up fibrosis as well as your pleural effusions. So I'm going to quickly show you one more, slightly more advanced view that Professor Swanevelder demonstrated, and that was the suprasternal view. And the patient with chest pain, this may be useful in looking for presence of a dissection, of aortic dissection. So in this view, it can be a little bit uncomfortable for the patient. You normally ask the patient just to lift their chin a little bit. Sometimes you may need to put a towel behind the back just to extend the neck a little bit. Orientation marker aims posteriorly, goes directly towards the patient's back, and we look for the aortic arch with a little bit of manipulation. So you can see here we've got the aortic arch coming up and over. I'll put on color just to demonstrate the flow of blood going down the descending aorta. So there's our descending aorta with the left subclavian coming off over here. It's difficult to see the head vessels.
Your scale, if you turn your color scale down, can you do that? Maybe decrease the depth of your...
Yeah, we can decrease the depth a little bit.
And maybe you see this frame rate.
And there we can see a little bit more of the left subclavian there. Okay. But it's, sometimes you may see the dissection flap, and if you are doing more advanced surgery like a TVAR, thoracic EVAR, you can actually see the introduction of the wire from below. Okay. What other views would you like to, shall we demonstrate? Of
got a few examples. If you,
I was going to quickly, let's go back to the apical four-chamber. I just want to demonstrate where M mode may be of benefit. So, Alma, can you turn onto your left-hand side again? Go. Great. So I'm going to go back to our apical four-chamber. I'm just, again, getting your depth correct is of uttermost importance. It's a pretty useless view here. You cannot see your left atrium or your right atrium. I'm going to change my depth until I get an optimized view. Okay. So M mode is your motion mode. This gives you one of the most high definition temporal views of the heart. And M mode involves one set of crystals continuously firing at all times, and it gets mapped against a time scale. I'm going to freeze this here. So what I've done is that I have now got a apical four-chamber. The M mode cursor goes through the lateral annulus of the mitral valve, and the more it moves towards the apex, the more the mitral valve annulus moves towards the apex of the heart, the better the ventricular function. So in this particular case, we've got a mitral annular plane systolic excursion of 1.68 centimeters. So it's more than 1.2 centimeters, implies good left ventricular function. Just remember that you are not an echocardiographer, but we are able to evaluate some basics that will allow us to exclude grossly abnormal ventricular function. And this is a reassuring finding in conjunction with other evaluations of ventricular, including ejection fraction and fractional shortening, that allow us to say that a patient has got a normal ventricular function. If I go to the same view and I put my M mode on the patient's right-hand side, I get, again, a similar equation, the TAPSE, or tricuspid annular plane systolic excursion, and you do a similar measurement and you expect it to be more than 16 millimeters. And in this case, it's well more than that. In fact, it's 2.3 centimeters. Again, not reassuringly normal. And there's been clear demonstration that abnormal TAPSE in patients with pulmonary embolus is associated with increased mortality. So it's a very useful measurement to take. It is a useful and easy tool in a point-of-care ultrasonographer's armory. So the last demonstration of M mode is going to be in your parasternal views. Once again, I'm going to change my depth. I'm going to optimize my view. And you're placing M mode through the middle of your ventricle. Got some very nice clear images there. Take a nice deep breath in and breathe all the way out. So on expiration, we have our best possible view. There we go, thank you. I'm making breathe normally again. So now on expiration, we've got our best view. So you can see the size of the ventricle in diastole, and you can see the excellent thickening of the ventricular wall in systole. And we can subsequently work out a fractional shortening and an ejection fraction using the software that's on your machine. I'm not going to go through all of that now. We can do it. That can be done at another stage. I'm happy to take any questions. Prof, do you want to demonstrate? Zoom out. Thanks, Omar.
Okay, are there at this stage any questions? If we have questions, then maybe, otherwise I will show a few more examples. If there are questions from the audience, and I'm sure the organizers on the other side would have collected them. Otherwise, we've got a few examples of interesting cases that will keep us going for the next 15, 20 minutes until the session is over, I think. Or is the time up already from your point of view? Is the time up?
So you can continue, sir, with any extra slides that you would have, sir.
We'll take the questions at the end if that's okay with you.
Okay, let's go for that. I'll go down to there. Just give me 1 minute to get to the right spot. Yeah, there. Okay. So thank you very much, Matt and Elmar and Robbie, and I hope that sort of could add to the, to the explanation why this is so valuable to our practice. I'm going to look at a few cases of hemodynamic instability, and Matt has talked about the Table Mountain, and I can tell you the Newlands cricket pitch is on the other side of the mountain on the left. Are we on there? We're on, okay. So the cricket pitch, Newlands, is on the other side of that mountain, very close to our hospital. And I can tell you on the 1st, 2nd, 3rd, and 4th of January, there's always an excellent international there. And with India's interest in cricket, we often see their team play there. So really nice to be so close. I'm going to start with this 33-year-old obstetric patient. And the patient has got hemodynamic instability. Now, the trick here is that, that this happened about almost 2,000 kilometers from here. So this, I would say, is the ultimate of telemedicine. Not everywhere in South Africa, they've got people with a lot of expertise, but most places or many places will have ultrasound machines available, and everywhere there are keen people who are learning. So this came from Pietermaritzburg when a colleague phoned me and said they've got this primigravida, 24 weeks gestation. And the patient has got HIV positive on retroviral treatment, acute dyspnea and hypoxia with severe preeclampsia, and now developing HELP syndrome. So the question is this peripartum cardiomyopathy, or is it just a preeclampsia, or is it a combination? And the attempted induction of labor failed. So now you sit with this patient with a sort of non-viable fetus, and the patient is in trouble. And the person on the other side, the obstetric anesthetist, did one of our courses and was good to get an echo image on the screen, and then took a picture of this, send it via WhatsApp to me, and asked, what shall I do? Now, I'm not a big obstetric anesthetist myself, so I immediately asked my experienced colleagues, Professor Rob Dyer and Dominique van Dijk, and say, what shall we do? And we looked at this picture and thought, this is not a it's not a perfect apical 4-chamber, but you can make a picture and recognize the structure. So immediately I could say the mitral valve is not affected. The tricuspid valve looks all right, but the left ventricle has got hypertrophic or concentric hypertrophy and really looks impaired. So either the afterload is hugely increased, or the patient's now got some sort of peripartum cardiomyopathy, which is a bit early in this pathology. We say, well, turn it a little bit, rotate it clockwise, and that was an apical 4-chamber. Now we're going to a parasternal short axis view, and this is what we see, and it's certainly a struggling ventricle, and the patient is now in big trouble. And then again, a parasternal long axis view, and I was looking very carefully at the aortic valve there and the ascending aorta. I was wondering, can that maybe be a dissection, which we know is common in the obstetric, or one of the common causes of obstetric hemodynamic instability, but it eventually turned out not to be. The patient's left atrium is not too big, the mitral valve opens, but there's certainly a very short ejection time, so there must be a very high afterload. So after a long discussion, the decision was made to do a hysterotomy under general anesthetic to stabilize the patient and to transfer to a tertiary referral hospital where they could then, which was about 150 kilometers away, where they could have strong cardiology support and they could make a diagnosis then of hypertensive cardiomyopathy. In other words, in our setting, preeclampsia is still very much commonplace. We see it a lot. And even eclampsia where patients undergo, fit, have seizures. But the patient was then treated accordingly and doing well. So that's a nice example. And since then, we've done studies. Elmarie Neethling, Professor Dyer was driving this. Elmarie Neethling was helping, and Clemens Ortner, Vijay Krishnamurti from Stanford in the States, they spent some time with us and we came up with this very nice publication in anesthesia analgesia of point-of-care ultrasound in the obstetric patient, and how it correlates with other biomarkers. I'm not going to go into the detail of the study. This is a 24-year-old patient, Gravida 1, Para 1, and 36 weeks gestation for a cesarean section. And this is now a transesophageal echo picture. See whether you can recognize some of the structures. We've got a huge left atrium closest to your transducer, which is in the esophagus. There's a mitral valve, which is restricted in its function and opening. Smallish left ventricle, dilated and hypertrophic right ventricle, and just under the color box here, we can imagine that there's some tricuspid regurgitation, with the intraatrial septum bulging across to the right side. In other words, a very high pressure with spontaneous contrast. So this can really not be much other than mitral stenosis, which again is pathology we see, a rheumatic heart disease in our country a lot. Patients come in from rural areas at a late stage and then comes into pulmonary with a pulmonary failure, pulmonary edema and cardiac failure. This case, the mean gradient under anesthesia was 8.3 and the maximum gradient 13. Now remember, we offload the heart when we go from spontaneous ventilation to anesthesia and positive pressure ventilation. And just there on the right side, there's a very, very tight mitral valve area and opening. If you use the pressure half time, 220 over pressure half time is 225. And in other words, the mitral valve area is less than 1 square centimeter. So again, look at the tricuspid valve, tricuspid regurgitation severe, the left atrium very much like a football with a septum bulging across, and this patient is in big trouble with if we use the Bernoulli equation, we say 4V squared plus the CVP. If we take the peak of our tricuspid regurgitation, it means that we've got a systolic pulmonary artery pressure of almost 70 millimeters mercury. This is huge, and this patient is in big trouble. Now, we just move on. Let me just see what else we've got here. Yeah, I'm going to stop there and ask whether we've got any questions. I think that's our transthoracic images and examples. So I'm going to stop sharing my screen now. And if there are questions, there's another 10 or 8 minutes left before the end of the session. So any questions from the audience?
Yes, so we have a few questions. The first question is by Dr. Avinash. Which method is more reliable?
Yes.
Sir, I'll begin again. Which method is more reliable for the assessment of hypovolemia The IVC diameter or the left ventricular volume?
Is it possible to use focus?
Yes, we can go back on the picture on this. If you can, can you go on our screen?
Yes, sir. You can share your screen, sir, if you wish to.
We will share our screen.
Do you want the slides?
No, we didn't know.
Not slides, just sharing. Yeah, video. Okay.
Do you want to see that?
Yeah. So
next to you.
come and sit next to me. If Robbie can come around and come and sit. Maybe if we move Elmar, you are obsolete now. Get out of the way, Elmar. We just rearrange our setup here, and then we'll. So, Robbie, can you squeeze in there? So, yeah, thank you very much. So I would say, if you want a quantitative number, then the IVC can give you a number. If you look at the left ventricle area or you look at volume, remember that the volume in 3D, we're looking at a two-dimensional picture. If we talk about a volume, then we have to calculate a 3D volume. Even with 3D ultrasound, we are calculating a volume or putting a data set together to come up with a volume. So with ultrasound, we are very good at eyeballing and pathology. We are very good with qualitative assessment of a picture. So we recognize a picture. Is the heart empty or is it full? To come up with a number is a little bit more difficult and less reliable because a number depends on so many factors. The question is, what is the afterload? What is the preload? What is the situation that you're in, the context? Is it a patient under anesthesia or is it an awake patient? So is the patient, on a trauma patient, maybe a high adrenergic drive, sympathetic drive at the same time. So all of those we have to keep it into context. So I would say it is fairly easy to look at the heart and say it's empty or it's full. The in-between is more difficult. The moderate impairment, the moderate filling or moderate hypovolemia is more difficult than to say it is severely hypovolemic or it's overfilled. You want to add to that?
So just make just a couple of comments. In terms of IVC variability has been demonstrated to be of benefit in volume assessment. Just remember that the IVC is part of the venous system, and the venous system has got a tremendous capacitance. And can take a lot of volume. It can, until it's actually stressed such that you have an overloaded IVC, you won't say that it's that you've got too much volume. So generally speaking, if you look at the IVC, the IVC the view I demonstrated just now, generally speaking, you'd expect it to be 2 centimeters or less. With some degree of collapsibility, more than 50%. If it's an IVC is more than 2 centimeters and there's no respiratory variation, there's no collapsibility, you can probably, really distended tight IVC, you can probably safely say you've got a CVP around about 15 or so. If, on the other hand, it is completely collapsing throughout the respiratory cycle and the patient is tachycardic, and you've got a small volume ventricle, you can probably very safely say this patient is hypovolemic. Always remember that you're not just looking at one particular view, you're not choosing just one measurement on which you're going to base your assessment. You remember you're a clinician first and foremost. You look at your patient as a whole, you apply your various examinations, you can use your stethoscope, although I believe the ultrasounds are stethoscope of the 21st century, and you look answer the question that you're asking, is this patient hypovolemic or not? And you'll look at your IVC variability, you'll look at your end diastolic volume, you'll look at the other measurements that will give you a clue that the patient is hypovolemic, and you put that all together when you're assessing the patient.
Yeah, I would add exactly what you say. It's all the context. If a young patient with a previously normal heart history comes in and they're hemodynamically unstable and they've just been in a car accident, and you see the blood flowing, then you don't need an IVC number or measurement to put it into context. It may be different when it's a controlled situation. And remember the sniff. When you ask a patient to sniff, a patient who's awake, and you ask them to sniff, and the IVC collapses. Yeah, so I think one must just, it's part of your ultrasound investigation, and I would first look at the ventricle, then take the IVC. And that's really to say, is the CVP less than 10 or more than 10?
Yeah.
You know, you can, it's been validated and correlated with the central venous pressure. So especially in the critical care setting, they use the IVC measurements a lot. If it's controlled or in a trauma setting, maybe not that much.
It's easy to manipulate with inotropes and with vasopressors, whether the patient's intubated and ventilated or not. Those are all going to affect your preload and how you're filling.
Any other questions? If that answers the question, any other questions?
Yes, sir. Thank you very much. We have a few more questions here. Dr. Jnanish Kamath wants to know, what is the role of transthoracic echocardiography in the intraoperative setting?
That's interesting. You say, Matt?
Okay, what I've found is that it's just a matter of having the courage to apply the probe. So a patient, the number of times in obstetrics where it is possible to monitor the patient's heart throughout using a standard transthoracic approach, your parasternal short or long axis. In pregnancy, there are certain advantages, in fact, when you do transthoracic echo, because of the changes in pregnancy, the elevated diaphragm is pushed up, the ventricle gets moved closer to the left-hand side of the chest, and the patient obviously is normally put placed with a wedge underneath the right hip, which allows the heart to become even closer to the chest wall, and becomes quite easy to assess the heart. So throughout, patient under spinal, even under general anesthetic, you can apply a transthoracic probe. However, in certain cases, thoracics, cardiacs, a transesophageal echo is going to give you a lot more information. It's going to be impossible if your surgeon is working on that particular area. But it's the only thing that's limiting you is whether you can find a place to put your probe. Some patients are easy to echo, some patients are not easy to echo. And if you're struggling with a transthoracic echo, is there a contraindication to transesophageal echo? Do I have the expertise? Is there someone I can call to give me assistance? Do I need to apply some other cardiac output monitor?
So, for instance, in hip and knee replacements, people have studied the embolization, air embolization, and also the cement embolization syndrome during the implantation of the cemented hips, and then used transthoracic transducers. Transesophageal, I've been involved and used transesophageal echo in those settings, but not published on that. But people, most of the publications in the orthopedic setting would be transthoracic. I concur with Matt about the obstetric setting. We've had a few practice runs here to see, and patients around the Caesar time, cesarean time, and fluid and changes, and we're busy setting up a study like that. There was one more thing that you mentioned that the question was about
transthoracic echo intraoperative.
Intraoperatively. Yeah, I think that's more or less. It's less because of the where the surgeons stand most of the time you don't have that much access. Oh, I remember now. What I wanted to say is that one of the vendors, I think it's Sonosite, has got basically a holder, a brace, which you can put on the chest so that you don't have to be there, that you can fix the probe on the patient's chest. And maybe that's something to revisit. I think a year or two ago, they came out with this, and where you don't have to hold the probe, but you get a good view and you fix it on the chest and then clean and drape the patient. So that would be good.
One last comment is that the transthoracic, often, remember, transesophageal echo is often less available. The machines may be used exclusively in the cardiac theatre, less available.
Probe is expensive.
Probe is expensive, and in certain cases you're not able to use it. Transthoracic is easily available, and in patients that have got sudden changes intraoperatively, we have a cardiac arrest due to argon gas embolism, cardiac arrest due to local anesthetic toxicity, cardiac arrest due to thrombus propagation, and transthoracic echo has allowed us to guide therapy, guide resuscitation, look for problems during the resuscitation intraoperatively. It's also allowed us to help assist with diagnosis. And in some cases where we cannot understand why a patient is hypotensive, when we've applied our usual cardiac output monitors and our systolic pressure variation, our stroke volume variation, it all appears normal. A transthoracic probe allows us to have a look and say, oh, this patient is actually completely hypovolemic, and giving volume reverses the amount of inotrope that we're giving to the patient.
More questions?
Thank you, sir. You brought out some really valid points there. Next question is by Dr. Anita Nileshwar. She wants to know, if a patient under general anesthesia develops sudden severe hypotension, how would one want to use point of care ultrasound? And is there an algorithm to rule out the causes?
You say hypotension.
Sudden hypotension.
Sudden hypotension during...
Logically, remember you're a clinician first. You're going to evaluate your patient, look for signs of bleeding, think logically, what is the most likely cause? If you've got a patient who's in a seated position, for example, and they're doing basic skull surgery, you're going to think of an air embolism first and foremost, and that's going to be the most likely cause of your hypotension. You look at your carbon, your CO2 outputs, and see whether that's something like that has happened.
What you say, Matt, is absolutely true. This is an extension of our clinical practice.
Exactly.
Now, if you ask specifically about ultrasound, then it is, like I said earlier, it's easy to see, is the heart empty or is it overfilled? Yes or no? Is the heart contracting or is it failing? Yes or no? Is there effusion around the heart? Very easy to spot, to see. Yes or no? A little bit more difficult is a wall motion abnormality, where you say, well, this is ischemia. No, usually it's any of the others before it becomes real ischemia, but it can be. So yes or no, and that's when the heart, is there dyskinetic segments? So is it, instead of during systole, moving out instead of in? And is it not thickening and staying thin? So that's usually the type of way I will use ultrasound itself. But of course, you have to exclude all the other. And yes, just to the previous question, good afternoon to Dr. Kamat, who I've seen long time ago, who asked that question. So it wasn't like we set it up, the question. Dr. Kamat, nice to hear from you. Any more questions?
Yes, so we have a couple more questions with us. Dr. Anand Kumar wants to know, how can we rule out pulmonary embolism with transthoracic echocardiography?
I think, Matt.
Yeah,
that's an easy one, Matt. Come on.
you can't exclude pulmonary embolism with a transthoracic echo, but you can see hemodynamically significant pulmonary embolism. We're looking for signs of acute right ventricular overload. We're looking for a shift in the interventricular septum. I demonstrated the parasternal short axis, where you can see the right ventricle and the left ventricle in short axis. And as you get an increase in right ventricular pressure, the interventricular septum gets moved across, and you start getting what we call a D-shaped left ventricle. And that's in a patient who previously had a normal left ventricle. You develop an acute increase in right ventricular pressure. Remember, the right ventricle doesn't take pressure very well, and starts affecting the left ventricle. And you start seeing those signs, and you are very concerned about pulmonary embolus. You may see other signs. It is possible to look for a saddle embolus in certain views, but that takes certain skill. And the lack of, if you're unable to see a clot, doesn't mean that the clot is not there. So you look for signs of acute pulmonary hypertension rather than the pulmonary embolus in and of itself.
I think to add to that is microemboli is one thing, and you may not see it.
Yeah.
But a huge embolus coming from a DVT, you may see in the inferior vena cava drifting around. You may see if you've seen a thrombus once, you'll recognize it anytime, because it may be in the right atrium, it may be migrating through the right ventricle into the pulmonary artery. Sometimes very difficult if it breaks up and it breaks into the pulmonary arteries on the left and right side. But Matt has explained very nicely the reverse Bernheim effect, where everything is pushed across to the left. The right ventricle does not like an acute increase in afterload. It can deal with volume very easily, but not an acute increase in afterload. And so that would be my story, to add to what Matt said. A big right ventricle, big right atrium, and a patient who is crashing.
Yeah.
One last query, sir. Not relating to the subject per se, but we've heard so much about TT today. We are eager to know, are there any online or e-courses to learn echocardiography, sir?
On your side.
Online tools.
Online tools. Yes, so we, so many. Matt, Eric's thing is a fantastic.
So there's two I can recommend, usabcd.org, which is set up by Eric Sloth. He's got an extensive e-learning package, which is available.
Just say that again.
usabcd.org. And then we can share the links at another stage. And then David Canty, Colin and Alistair Royce have set up excellent focused ultrasound training from the University of Melbourne. I can't remember the exact address. iHeartScan.org. Two excellent online platforms. Just remember that the e-learning is, of course, essential, gives you the basics, goes through the physics as well as the basic views. But in terms of the actual practical application of ultrasound to the chest, it's always best to have someone just to guide your hand. And there are a number of courses set up all around the world. I was in Chennai as part of the Ramachandra Anesthesia Continuing Education 2019. We did workshops over 3 days, 1,200 delegates, and it was a great opportunity for delegates to put their hand on the probe and to actually see what they could see in the patient's chest.
Thank you very much.
Thank you, sir. This brings us to the end of our question and answer session. We'd like to thank Dr. Swanevelder and his entire team for this very informative talk. And we hope that we've managed to convey the importance of the transthoracic echocardiography and our role as perioperative physicians. Thank you, sir, for graciously answering the questions. And as a token of our appreciation and gratitude, please accept this e-certificate.
Thank you very much.
We will definitely, and if you give me just a second, I just want to say the fond memories I've got from visiting Manipal in the early 2000s, meeting up in Bangalore with Dr. Venkat, also colleagues we've worked with in Leicester, and visiting people there, and I was so impressed with your anatomy museum. I've still got pictures when I teach on anatomy and the live heart demonstration. I've got that heart with the red and the blue that you've got in your Dr. Pai's museum there. So Kasturba, thank you very much for inviting us, and Anita Shenoy and Dr. Manju Nath Babu. Thank you for that.
Thank you, sir.
As the day comes to an end, we would like to thank our speaker and all those of you who attended today for your participation. Before we close, a reminder about the feedback forms, which will be available on the APGAP website from 8th November to 10th November, 10 p.m. Kindly fill in these feedback forms and submit it to receive your e-certificates. Those who have registered with the Medical Council registration number before the 28th of October and have attended at least 4 sessions will be credited these CME points on their e-certificates. Others will receive a participation certificate without the credit points from the organizing team. Stay tuned for another info-packed workshop session tomorrow on the anesthesia machine by the well-known Professor Dr. Pankaj Kundra. Hope to see each and every one of you again. Signing off, take care, stay safe.
All went so well.